to a Thursday VMR. I'm super excited to co-discuss with Rabih today, and we have Gerardo, who will be presenting a case for the first time, which is so exciting. So Gerardo, I'm really looking forward to this. And do you want to unmute and introduce yourself?
Yes, well, hello everyone. My name is Gerardo Luna. I'm from Lima, Peru, and I'm a medical student. Right now, I am in my 4th year of 7 years of training here in Peru. And I'm so excited to present the case for you today. I hope it is going to be fun.
Gosh, y'all, I think it's going to be incredibly fun. I've been so excited for today. In fact, as the folks on CP Solvers know, we actually weren't going to have a session today, but somehow made it happen and late last week. And it's crazy how it's turned out to be. And I think from my lens, this is unreal because I actually on my drive back here, Maddie, I was thinking about when I first saw you turn your video on. Well, at least when I first noticed that your video turned on, which was probably not. On CP Solvers VMR a long time ago, and I was reflecting on how I still remember your one of your first presentations when you presented a patient with COVID who developed cholangiopathy and cirrhosis. And just thinking like I could hear the nerves in your voice and and the angst that you had, and now to see you co-leading the whole CP Solvers organization, still leading VMR, somehow having more tentacles than an octopus does with all that you do within CP Solvers. It's incredible. It's absolutely incredible. So really psyched for today. And I think it's very fitting that Gerardo is presenting a case today because I feel like there are very few people so early on in their training like Gerardo who have had and demonstrated the unbelievable passion for clinical reasoning and medicine. He like cold emailed us his story and his passion for this. And I was amazed to see the schemas that you shared with us in our private channel, Gerardo. And it's a very fitting. I can easily see you following the footsteps of the legendary Maddie. And I think it's just perfect that we get to hang out today. So yeah, without further ado, let's take it away.
Thank you so much for the words. They are very kind. And well, now we can start. And well, for the first aliquot, we have an 80-year-old female that comes to the emergency department with jaundice and abdominal pain.
All right, we can pause here. So an 80-year-old woman with jaundice and abdominal pain. So we've talked about jaundice probably more than a few times on VMR, but the way I think about jaundice is I translate jaundice to hyperbilirubinemia, and then there are kind of two frameworks I have in my head at the same time. I either think of jaundice as prehepatic, intrahepatic, posthepatic, or as I've learned from Rabih, which I think is so helpful, like, is this a heme issue or is this a hepatic issue? And if someone is presenting with jaundice and abdominal pain, one question we can ask ourselves is, just from like these 7 words on the board, like, is there any way we can make progress and try to guess, is this going to be a hepatic issue or a heme issue? One way is to think about that is if someone has jaundice from hemolysis, they need to have very severe hemolysis to the point where they are probably like very hemodynamically stable, and that likely won't be the chief concern. So my prediction is that with this person with jaundice and abdominal pain, I think that's, I'm thinking that this will like more likely be a hepatic issue. But ultimately, those are kind of the two frameworks I use, like pre, intra, post hepatic. I think is this heme or hepatic. And then, of course, like for any chief concern, you kind of want to have a list of do not miss causes that should be on your radar so that you don't miss something that's highly morbid. So those are things like acute liver failure, cholangitis, hemolysis, and then in someone who's in their older age, so 80 years old, if this is a hepatic issue, you'd want to see if there are signs of chronic liver disease on exam. So things like portal hypertension and high estrogen. So that's those are my initial thoughts, but kind of practically I'd want to be asking the time course. Abdominal pain has its whole differential for like do not miss causes, but really I think the time course is something that's critical here. And I'd start with that. I'm curious, Rabih, like any other kind of, what else is going through your mind?
What was honestly going through my mind is when Maddie's fiance says that Maddie loves something, you certainly pay attention to it. And we're hearing that you love jaundice. So I think it's very, very obvious that that's the case. I don't have anything to add, but we'll tell you that to summarize and then add one very, very nuanced observation is you're saying jaundice is either heme or hepatic as a gross oversimplification, and you're saying that the presence of abdominal pain prioritizes hepatic, and the lack of any signals currently to any cardiopulmonary diseases further reinforce that notion by making heme less likely. And the cardiopulmonary symptoms here would be no shortness of breath, and no chest pain, etc. And that's superb. When you are in hepatic, as you said, you mentioned acute liver failure and cholangitis. And I think one thing to reflect on really fundamentally within hepatic is what you're really trying to do is what you try to do with the kidney. You're like, is it intrahepatic in the liver itself, the actual big parenchyma, or is it posthepatic in the drainage ducts? And here's a very interesting thing for you all to track. It's definitely not been studied, but I want you all to go to a mental space, if you have access to it, where you've seen a patient with parenchymal liver disease show up with jaundice. So go back to examples of cases you've seen in real life of patients with cirrhosis or patients with acute liver failure or any parenchymal issue you can think of that is severe enough to present as jaundice, meaning bilirubin of around 4 or 5. How many of those cases in your mind is the patient able to tell you a good story, a strong, robust chronological history? Because I'm picturing this patient right now in my head. I've seen many of them. And if the jaundice is intrahepatic, the vast majority of patients will have either cirrhosis or significant liver injury. And the liver injury will be so significant that they will be impaired in their ability to excrete CNS toxins like ammonia, and often have some degree of neurological compromise, either subtle or overt. And if Gerardo proceeds to tell us a pristine chronology of events related by the patient alone, signifying that she has a strong command of what's going on, I'm leaning so strongly extrahepatic, because those simple bile ducts do not have the complex job of having to process all the things the liver has to clear that keeps us from getting confused. So it's one rule of thumb. If somebody says, hey, doc, I'm jaundiced and my belly hurts and this happened and this happened and this happened, I'm like, yeah, sure. It could be an acute mild liver injury on its way to becoming liver failure. Not there yet, but geez, do I lean stronger in the extrahepatic category. The more action there is, coagulopathy, thrombocytopenia, CNS, the more the complexity of the liver comes into play. The more silent and painful the diseases, the more it is in the simple plumbing of the extrahepatic tree. So I'm really excited to see if that rule of thumb, it's not bulletproof, but that rule of thumb helps us here today. All right, Gerardo, tell us more.
Great discussion so far, guys. Well, now we are going to proceed with the HPI. And well, her daughter reports that the patient has had a mass on the lower right side of the face of her face for 3 months, progressively growing, painless, which, according to what she reports, has not interfered with her daily activities. In addition, she reports that 15 days ago, her mother began to present abdominal pain and her skin color became progressively more yellow. She reports that in the last 10 days, her mother has been losing her appetite and her bowel habits had changed from once a day to once every 3 days. Due to the worsening of her condition, her daughter decides to bring her to the emergency department. And that's all for the HPI.
All right. I must say, I was not expecting you to say that there was a mass on the face. I just did not think that the case was going to go in that direction, but fascinating. So what we learned in this aliquot is that what stood out to me first was that it's her daughter bringing her into the emergency department. I think that kind of goes off what Rabih said. I'm not quite sure what her mental status is, but one potential kind of jump you can make from the fact that her daughter brought her in is maybe she's confused from like liver injury that's not able to metabolize all kind of the things that make someone confused, like ammonia. And so maybe that would point towards like an intraparenchymal kind of origin of the jaundice. And so let's see. So we learned here that there's a mass on the patient's lower part of the face, and that in the last 15 days, there's been abdominal pain, the jaundice, and then decrease in bowel habits. So some of the things that are going through my mind are like, is the mass just an incidental part of this, or is it related to the current presentation? One thing that crossed my mind is, was someone concerned that the mass was infected and so the person got antibiotics and then there's like drug-induced liver injury from that? That's like one thing that my mind went to, but I think that mass could either be integrated or it could be a red herring. So that's kind of one thread that I was thinking of. And then we have this 15 days. That's kind of like a subacute abdominal pain and fewer bowel like bowel movements. So I think I am, sorry, I'm a little bit all over the place, but if we go back to like jaundice as heme or hepatic, and we're thinking more of the hepatic because of the presence of abdominal pain, and we're trying to think, is this intrahepatic or post-hepatic? An argument for this is intrahepatic is maybe there is altered mental status, which is why the patient is being brought in by her daughter. I think what's concerning that the bowel movements have decreased, like, is there some sort of bowel obstruction? That'd be kind of like the worst case scenario that we'd want to rule out. But ultimately, I think practically for next steps, some of the additional questions I would be asking are what medications the person is taking. Have there been any changes to the medications to get at liver injury? I think ultimately this person is like heading in the direction of a CT scan because of the like bowel habit changes and wanting to make sure there's not a bowel obstruction. Because for abdominal pain, I'm kind of thinking through the do not miss causes with the vipomnemonic, like the vascular, the inflammation, the perforation, and the obstruction. So that's what's going through my mind right now. I'm curious, Rabih, like, what other information you think is like really pertinent to focus on right now?
Yeah, no, Maddie, I think a kind of simplistic way to approach this is to ask yourself, one, do you think this is a systemic disease or a localized disease process? And that seems to be a simple question to answer here, which is that, this patient has a problem here and a problem in the belly, a problem maybe in the GI tract, and a problem in the heme or hepatic. So it's very plausible to say that I think most people would agree that this is a systemic disease. And a 10,000-foot view of a systemic disease process is to ask, is it a space-occupying systemic disease process? Or in simple, even simpler terms, is it a mass-forming systemic disease process, or one that is radiographically negative? So an example of a mass-forming disease process would be metastatic cancer. An example of a radiographically silent systemic disease process would be something like iron deficiency anemia. Not making an argument that's happening here, but gives you a sense of how we go about thinking about this. And so, what would you say your sense is? Would you say this is a mass-forming systemic disease process, or a radiology is going to be inconclusive or not helpful here?
Let's see. I'm a little bit influenced by the fact that there is a mass in the face. Like, does that mean that there's a mass forming?
I think that's okay. If the patient's like, kaboom, there's a mass here. I think it's okay for you to be like, oh yeah, I think this is a mass forming process. And then starting with that hypothesis, what does the bowel habits make you think of in terms of the analysis of mass or no mass?
I'm trying. So like how the change in bowel habits can help us make progress on if it's a mass forming or not. I'm not entirely sure actually, because I feel like I can think of, I don't know, like if it's a mass forming process that's like maybe impeding into the lumen that's causing fewer bowel movements, like that's a way to kind of connect it. But maybe also if there's, I saw in the chat someone put like hypercalcemia, like maybe that's a way with the constipation. So those are like, that's not a mass forming process. So I think I'm not really sure.
Yeah, 100%. You're right that the vast majority, like we call this increasing constipation. The tempo of the disease would tell you that you should worry about a space occupying process and obstructive constipation. But in a patient with a systemic disease process, hypercalcemia is really important to think about. But if you start to gain momentum and say, okay, I have reason to think about a mass forming disease process because this patient literally has a mass on the surface of her body. I have another reason to entertain that line of thinking because this patient's presenting with relatively acute constipation. None of those things are definitive, but then you can start to ask yourself the key question that I was trying to lead us up to, which is going back to the initial calculus, intrahepatic or extrahepatic? If you have a systemic mass-forming disease process, where do you think that mass-forming disease process is more likely to end up? In the intrahepatic biliary tree or the extrahepatic biliary tree? What do you think?
Extrahepatic.
Yeah, if you have an extrahepatic disease process like pancreatic cancer or cholangiocarcinoma, that can definitely metastasize to everywhere. But if you have a systemic cancer or mass process like a lung cancer or a breast cancer or a salivary cancer or a lymphoma, where do you think that ends up?
Probably the liver.
Yeah, exactly. So from now, you can ask yourself, is a neck mass a common site of metastasis of an extrahepatic process?
I don't think so.
Yeah, right? So you can start to say, okay, I think this is a mass forming disease process based on this, reinforced by the abdominal stuff. It could be extrahepatic spreading everywhere, or it could be something spreading to the liver. The fact that it's in the neck doesn't really add up with pancreatic cancer or cholangio at first glance.
Yeah.
So you're like, I bet the pattern is such that this is a systemic disease process that has then gone on to infiltrate the liver and the extrahepatic parenchyma, which is also in line with the sequence of events that the patient reports, right? Like how this thing evolved. So I'm just, what's my goal here of this whole conversation? Maddie, we're literally 3 minutes into the evaluation here, right? Most of the time, you don't have time to do this thinking. You're simply saying, tell me the bilirubin, tell me what the imaging is, and then I'll start to solve the problem. Medicine for far too long has ignored the tremendous value and the amount of information you can extract out of the history from a patient. And I am sitting here right now giving this person an 80 to 90% chance of having a mass forming intrahepatic disease process just from the history. Now, could I be wrong? For sure. It's way too early to lock in, but I think there is so much information to study in the history that often gets overlooked. And the pearls here are jaundice without a cardiopulmonary signature and abdominal pain, liver. Liver plus systemic disease process either means Mets from the hepatobiliary system or Mets to the liver, and the pattern can help you tease them out. And if we later learn that this patient is not telling us the story and is leaning on her daughter because she's confused, whew, locked into the liver. So locked in that it will take me a lot to remove myself from that hypothesis. Any questions about any of that? It's very, it's trying to get a lot of juice, maybe too much out of the HPI, but I think it's possible.
Yeah, no, that's just that was very cool and very enlightening. I no questions right now.
Okay, all right, cool. All right, Gerardo, tell us more.
Great discussion so far, guys. And now for the past medical history, where her past medical history was notable for hypertension, which was treated with losartan, the only medication that she takes on a daily basis. Family history was unremarkable, and she denies any alcohol, drugs, tobacco, or caffeine consumption. She also denies having any allergies. And I'll pause there and hear you guys.
Yeah, I think what stands out, I think the main part that I was looking for here, very much influenced by the case that Jazz presented to me. I was like, is this patient on any meds or any supplements or anything that can cause direct liver injury? So I was really on the lookout for that, but I don't see any. So that's kind of the main thing I'm taking away from this. They are on losartan. I'm not aware of losartan causing liver injury. That could be a gap in my knowledge, but that doesn't stand out to me as an obvious one. And no alcohol, I think that also is important because, you know, like alcohol-associated liver disease is just so common. So like if there was alcohol use, that would be something that would have like stood out to me about, is the alcohol use contributing to like chronic liver injury leading to the jaundice, but there's no alcohol in this case. So I think this is all helpful, kind of pertinent negatives. Yeah, what about you, Rabih?
You know, I really admire your ability to pick up on the pertinent negatives. Just today, I'll actually present this case on RLR in the future. Just today, the reason we were able to get to the bottom of the case was only because of pertinent negatives. And so noticing them and acknowledging them is huge. I completely agree. This was the key part: meds, and exposures, and no known exposures. We'll revisit that if the case builds for one that isn't, that we'll have to reassess and go back to it, but I completely agree. Very helpful, pertinent negative. Gerardo set us up with a juicy history that gave us a little bit of a break. So I'm really curious what's going to happen in the exam, but I just wanted to take a second to acknowledge the incredible work that Jimena is doing on her first time scribing. It's so cool to see you crushing it, and how Francisco is building his first ever teaching point section. It looks incredibly well organized. So I'm excited to see it all happen. All right, Gerardo, tell us more, please.
And yes, guys, so for the next aliquot, we have the physical examination. And well, first the vitals. Her temperature at admission was 37. Her heart rate was 96. Her respiratory rate was 20. Her blood pressure was 100/70. And her oxygen saturation was 95%. For the general examination, she was somnolent, ill-appearing, with evident jaundice, and globular abdomen. For the HEENT, her eyes were with a scleral icterus, cervical mass of approximately 6 centimeters in diameter at the right angle of the mandible, rubbery consistency, painless, without signs of inflammation. Everything else was unremarkable. For the cardiovascular system, there was positive jugular venous distension and otherwise was unremarkable. For pulmonary, there was dullness to percussion in the left lower hemithorax with decreased tactile fremitus and faint breath sounds. For the abdomen, there was diffuse increase in abdominal consistency, especially in the right upper quadrant, with a discrete palpable mass. The liver span was of 9 centimeters, and there was no palpable spleen. There was increased dullness in upper quadrants, with no ascites, no evident hepatomegaly or splenomegaly to palpation. And for the neuro exam, she was sleepy but oriented to person, time, and space, and everything else was unremarkable.
Wow, this is an amazing exam, Gerardo. Wow, so detailed. But did you have anything else to say? I didn't mean to cut you off. Or was this the end of the aliquot?
No, it was the end of this aliquot. Now
Okay.
I'll hear
I'm
you.
very excited. All right. This is very interesting, and there's a lot to unpack here. So starting at the vitals, my overall impression is like nothing stood out to me, I guess, from the vitals. I was kind of reassured, actually, but I'm not sure if that's false reassurance. So to go maybe systematically, somnolent, ill-appearing, HEENT, scleral icterus. So I feel like from past VMRs, I've heard like if you have scleral icterus, that can kind of help predict the bilirubin level. I think it's, Robbie can correct me, but like if you have scleral icterus, the total bili is like around 4 or 5, if I'm remembering correctly. The 6 centimeter mass at the right angle of the mandible, that is really standing out to me. And I'm really curious what that is. You know, I think if the mass, like in general, is a mass an infectious process? Is it malignancy? Is it benign? You know, there's a lot of lymph nodes in this area. So is the mass actually just an enlarged lymph node? I think 6 centimeters, I'm like less concerned that this is an enlarged lymph node, but that's just something that came to mind. And so I would want to kind of clarify, like, is there like diffuse lymphadenopathy, or is this really just like this one mass? Is that the only thing that's palpable? The fact that it's rubbery, I'm not exactly sure what to make of it. I'm not really sure. The jugular venous distension, I was not expecting that. So that points to me like, is there some kind of heart involvement? Is there some like right heart failure that's going on here? If that's the case, maybe I would expect to see some lower extremity edema, which we're not seeing here. So I'm not entirely sure how to tie that in, but that to me, like the jump I made there is like, is there an issue with the right heart, basically? Pulmonary dullness to percussion and the left lower hemithorax, breath sounds. So I mean, just to kind of step back here, I'm thinking about the conversation that Rabih and I had with the history, and kind of from that, we were concerned about this systemic mass forming process. And this physical exam could be consistent with that. Like, maybe there's a mass, there's a mass in the neck, the dullness to percussion, are there some consolidations or masses in the lungs? There's also diffuse, I'm just thinking of the abdominal exam. So I'm kind of forgetting what a normal liver span is. So it's 9 centimeters. I'm not sure if that's enlarged, but I think you said no hepatosplenomegaly and no papillary spleen.
Maddie, just to make sure that you're solving the the right data. I think Gerardo mentioned that there was a discrete palpable mass in the right upper quadrant. Is that right, Gerardo, or am I just reinforcing my own biases here?
Yes, the examination reported that, and like discrete palpable mass, discrete meaning like it wasn't really the examiner and I, because I actually did the examination too, and really didn't notice like like 100% sure mass that was palpated, but the consistency was increased.
Okay, so a suspected abdominal mass, is that right?
Yes.
Okay, so yeah, basically just kind of going back to the hypothesis that Rabih had about the systemic mass forming process, I think there are signs to point to that here. So there's a suspected mass in the abdomen, there's this mass in the right mandible, and potentially also in the lungs with the dullness to percussion, and I'm not sure what's going on with the heart. So I think for masses, the very simplistic is like, is this an infection or is this malignancy? There have been some, like for infections, just one that jumps to my mind is like tuberculosis, which can, I think there was a case of it causing like an ileocecal mass. So there's a whole kind of differential probably for infectious, but that's just one that stood out to me. But I think here the summary is that there are suspected masses in like diffusely throughout the body, and I would want to get some imaging to better characterize those. That would be kind of my next step. But this is very kind of odd to me, and pretty concerning.
Yeah, no, I completely agree with you, Maddie. I think I think most people would probably stop and analyze the data with the exam now. And now you're like, I literally feel a mass in the neck. I feel a mass in the abdomen. And I think the strict interpretation of decreased tactile fremitus and faint breath sounds. So tactile fremitus and the reduction in tactile fremitus and the faint breath sounds are suggestive of fluid being between you and the lungs, which is why there's reduced tactile fremitus and faint breath sounds. And so that you can translate to the probability of having a left-sided pleural effusion. And in addition to the mass that Gerardo palpated in the abdomen, there might be some fluid in there too. So when you're thinking of a systemic mass forming disease process, you should also recognize that these masses very frequently liquidate, and metastatic cancers and infections commonly have serosal effusions as a part of them, pleural effusions, peritoneal effusions, ascites. So you're seeing the liquid and solid phases of a mass forming disease process, I think. And what really breaks the symmetry is the presence of the jugular venous distension. And I think that's really, really key. And I also was not anticipating that. And so if we step back and start with something else for a second to link it back to the JVD, which is we're worried about masses. The age of we're worried about masses we should think about translate into an inflammatory disease process, infection, malignancy, and autoimmune. And in general, autoimmune diseases don't tend to form masses. There are very notable exceptions, and actually the exceptions are so notable that you can form a specific differential for mass forming autoimmune disease. And IgG4 disease and histiocytic disorders are the champions of that, but they're super rare, and especially rare in older adults. So when you're thinking mass forming disease process, you're like, is it pus or cancer, practically speaking? And in an older adult without prominent signs of inflammation so far, you have to think cancer, but the no misdiagnosis is an infection. So if you go down the cancer as your leading thought and you try to merge that with right heart failure, I know you got some practice thinking about cancer and heart failure with a mind-blowing case on Monday of leukemic myocardial infiltration. But if we think more practical than that, what do you think of with cancer and then patient having right heart failure? Oh, I think you're muted. Yeah, I think you're muted.
Sorry.
Okay.
Yeah, so So cancer and right heart failure. I think my first thought is something infiltrating the myocardium, like leukemic infiltration.
Yes.
I'm trying to think if there are other examples, but I'm sure lymphomas infiltrating the myocardium. What else can infiltrate the myocardium? Could something maybe also be like compressing on it?
Yeah.
Like if you had a lung cancer, could it like end up compressing on the heart, causing right heart failure?
Yeah, absolutely.
I'm just thinking of something like compressing the heart or something infiltrating into the myocardium.
Oh, but that's the key. That's the key thing to think about. The truth is that while we don't have to think about it in this case, treatment-related toxicities from the cancer are much more common than cancer itself, chemotherapy and whatnot. But that's not something we have to think about in this case. So if we're strictly thinking cancer plus heart failure, cancer invades the heart from outside in, and the most common complication directly related to the heart is a malignant pericardial effusion. And after that are much less common causes, including myocardial infiltration and even the possibility of a pulmonary hypertension from a tumor, many rare causes. But I have to tell you that heart rate of 96 becomes really important now. Because if you're saying I'm worried about a cancer, if you're saying that I have a JVP elevation, and the patient is borderline tachycardic, the idea of a malignant pericardial effusion with borderline tamponade physiology has to cross your mind. And the tamponade and pericardial effusions are can be so subtle and so scary, and the patient can decompensate very quickly. So I think we've now really locked into the idea that this person has a systemic mass forming disease process. And the tempo here is reassuring. It's subacute, which often means you can take your time. But when there's something that's subacute that's building under pressure, that pressure valve can pop. And that's the concern in a patient with a JVP and borderline sinus tachycardia with a concern for cancer. So all I really want to know next is, does this patient have fluid around their pericardium? No different than they have fluid around their lungs.
Mm-hmm.
That's the first thing I'd want to know in real life. Of course, we're doing a diagnostic reasoning exercise here, so Gerardo may choose not to present information in that order on purpose, but in real life, cancer plus heart failure, pericardial effusion until proven otherwise, because of how deadly it can be.
Mm-hmm.
All right, Gerardo, tell us more, please.
Yes. Well, for this next aliquot, we're moving to the labs finally. And well, for hematology panel, her hemoglobin was 8.8. Her MCV was 78.9. Her MCH was 27.7. Her MCHC was 35.10%. Her platelets were 163,000. Her white blood cells were 16 and 750. And there was an observation of anisocytosis with 2 cross and target cells of 2+. Anisocytosis of 2+ and target cells of 2+. For chemistry, her electrolytes were, she had a sodium of 138, a potassium of 3.59, and a chloride of 97.6. For her complete metabolic panel, her AST was 331. Her ALT was 179. Her GGT was 1044. Her total bilirubin was 11.92. And the direct bilirubin was 11.4. The DHL was 510. The albumin was 1.86. The total protein was 4.43. The INR was 0.97. And the PTT was 44.1. Her urea level was 166. Her creatinine was 1.83. The uric acid was 7.67. The amylase level for the pancreatic enzymes, amylase level was 79, and lipase was 67.4. And lipids and total cholesterol was 180. HDL was 14. LDL was 28. And triglycerides were 224. And some additional lab studies were conducted. And well, she had some serologies for viruses, common viruses, and they were, well, it was negative for HCV, it was negative for HBV, it was negative for HIV 1 and 2, and it was negative for HTLV 1 and 2. Also the BDRL was negative. The beta-2 microglobulin was 11.27. And finally, the CRP was 20 and 22. Yeah, I know that, that they are quite a few labs, but yeah, they are going to be important for discussing the case. Now I'll let you guys talk.
All right. Wow. Gerardo, I just must say that you're doing an amazing job presenting this case, and I'm learning a lot just discussing it, and simultaneously learning a lot and also quite confused. So that means it's a good case. All right. So I think my overall sense here is that this patient is very sick, which we already got a sense of from the physical exam. So just to kind of go from the top here. So she has a leukocytosis. My first question is kind of what is the differential on that? I'm not sure if you have that, Gerardo.
You mean the neutrophil count?
I was just
yes,
wondering. Yeah.
I can. Yes, I don't have it like
No
right
problem.
now, but if you give me like 1 minute, I can find it.
That is no problem. I think I will assume right now that it's neutrophil predominant, but that's just something that I kind of always, it's like the next question whenever I see an elevated white blood cell count. We see a normocytic anemia. It's like slightly on the lower end, so on the border of microcytic, and a normal platelet count and target cells. I'm kind of forgetting how to think about target cells. I know people put some things in the chat, but to be authentic, I'm not sure what to make of the target cells, but I think just from the CBC itself, is that from like an anemia of chronic disease picture here? I don't think it's an under production issue. I'm not so concerned of blood loss here, but that's just something that stood out to me. I think for the chemistry panel, we were anticipating the elevated bilirubin level. I was not expecting to be 12, so we're seeing a direct, so that kind of reinforces that this is either, it's not prehepatic, so this is either intrahepatic or posthepatic. I also look for kind of, then my mind goes to like things that the liver produces, so like albumin, for example, and I believe that's low. Is that right? So I'm concerned about the liver function. We also see kind of like an abnormal INR and I believe an abnormal PTT. So I think to me, those things are pointing to impaired liver function, basically. So I think that continues to like support like an intrahepatic issue because the liver is not doing its job by like making albumin and making clotting factors. what else do we have here? So we have elevated AST, ALT, very, very high GGT. Do we have an ALK phos? I'm not sure if I didn't hear.
Yes, I didn't report it because there wasn't any alphas in the tests that were ordered. So
No,
we only have the GGT. Yes.
no problem. Yeah. I guess the way I think of the GGT is like if there's an elevated ALK phos, I look for the GGT to see if it's like hepatobiliary in origin versus the bone or something. So I think that if the degree of, I'm not sure if the degree of GGT corresponds with like the degree of ALK phos, but that seems to be like a really, really high GGT. So maybe that, I'm not sure if that helps us make progress on like intrahepatic versus post-hepatic, to be honest. But I think with like the abnormal albumin and the abnormal INR, I'm concerned about like intrahepatic issues. So like, I guess just to summarize, what am I taking away from this? I think I'm concerned. Let's see, maybe just to back up. So basically this is an 80-year-old female who's with like no reported history except for hypertension, who's presenting with subacute jaundice and masses in multiple locations. Kind of concerning for, I think this is still concerning for malignancy in multiple places, with like a negative infectious workup so far. I think my next step would be to get imaging to see if there are, we are suspecting a lot of masses, so to try to further characterize those masses. And that is where I'm at. Rabih, I'm curious, like with all of these labs, like what did your mind focus on as things that are helpful versus not helpful?
No, I completely agree with you. I really admire, and this is a lesson for all us all, is when you're like synthesizing, you often have to go forward and go backward, go forward and go backward. And I think the way what you just landed on is so powerful. I am right there with you. And I think what you can take away from this exercise is to realize that that branch point of systemic mass forming versus radiographically occult helps you predict the relative investment in imaging versus labs. So Maddie, all I have to say in this aliquot is just hold on to how much progress you've made with the labs and now compare it, maybe, to the progress we're going to make on imaging and compare those two. It reinforces the value of having that initial schema of, is it mass forming or is it occult? And my experience would say that if it's occult, labs are the money shot. If it's mass forming, the imaging is where I'd start. And then integrate the labs. And yeah, in retrospect, we might look at some clues on the labs, but I think in real life, the imaging would probably be my place to start. All right, Gerardo, tell us more, please.
Yes. So for this next aliquot, I have the imaging, and I actually have pictures of the studies that were performed, so I can share my screen for you guys while I also describe what the radiologist reported. So first, this is the patient that was blurred out, but you can see the mass, but I don't think it is being shown right now, is it?
Oh, yep, no.
Yes, right now I think it is shown. And well, this is the ultrasound of the bile ducts, and this is the abdominal ultrasound. And the radiologist reported that it was hydrocholecyst and moderate hepatic steatosis and dilated intra and extra hepatic bile ducts. And well, now I have the CT scan, and the CT scan, well, I don't have the radiologist report, but I can show the images for the discussants to analyze them, because they said that it was going to be ready in like 14 days. So I just couldn't get them. but I can show you guys. So I'll go slowly for you to look at them. It is a video that I took from the computers there in the hospital. So yes. Yes. I don't know if you want me to repeat, but because I have another video too. And this is
Oh my gosh, this is really tricky. I'd say, Maddie, I definitely see a left-sided pleural fusion. That's the only thing I'm confident about, honestly.
Yeah.
What
and
side?
this is just a picture.
Oh yeah, go ahead. Sorry, go ahead. Yeah.
Sorry. I just wanted to show some pictures in case you didn't see the video very close. And this is the cross-sectional from the lungs, and this was from the coronal section of the abdomen. And yes, those are all the imaging studies that I have.
Yeah, so all right. So I think, you know, going into these imaging studies, we were concerned about a mass forming disease process. As Rabih said, I think the clearest thing I saw, as Rabih said, was the left-sided pleural effusion. I was really keeping my eye out for, like, is there a mass around the liver? And I may have seen it, but to be honest, I'm not entirely sure. So I would really rely on the radiologist. Probably what I would do is really talk to, like, I would call the radiologist and speak to them about what they're seeing, and tell them I'm concerned about a mass forming process, and especially in the liver, and ask to kind of go through it with them. So I'm actually not entirely sure what I saw there. Maybe there was a mass around the liver, but I'm not sure.
Yeah,
But so, but yeah, eventually you probably need to biopsy something to get an answer.
yeah, you know, Maddie, I think this is so interesting because it just goes to show you how much we rely on radiologists in real life. Like my confidence level just plummeted because of the fact that we can't lean on experts to look at these pictures and tell us. I think the little bits of information that we did get was that this person has extrahepatic and intrahepatic biliary duct dilation, right? And so it tells us that there's a component of this disease process that is extrahepatic in nature. And it makes you wonder whether she has a massively impacted stone, or whether she has extrahepatic cancer that's going everywhere. We also don't see a great explanation for the pericardial, for the JVP elevation, though it might be simply mass effect from the left pleural effusion, which can happen. So yeah, I think that the gap in the radiology, it leaves us much less confident with how to accurately solve this problem. And so the little snacks that we can pick up on are extrahepatic and intrahepatic biliary duct dilation, large left-sided pleural effusion, and then the gallbladder. You saw that gallbladder was like massive.
Yeah.
So gallbladder distension, maybe because of an impacted stone, or maybe because of malignant obstruction. So I'm right there with you. I don't know what to do next, but I think we can agree that when you have so many things on radiology, often a biopsy or cytology or analysis of the fluid or analysis of these masses will be very, very productive. But Gerardo, you have us on the edge of our seats. Tell us what you all were thinking and what you did next.
Yes, this next aliquot is the diagnosis, but I don't know if I heard well. Did you ask me to share with you what was the thought process behind?
Maybe Gerardo, you can tell us what you guys were thinking the imaging I know you don't have a radiology read, but what were you, before you tell us the answer, so we can think it through, what were you summarizing the pertinent radiology findings to be?
Well, when we got the CT scan, where we were, because we really had one suspicion in mind for the diagnosis of the patient. So I was thinking that there would maybe be a mass that it was in the hepatic ileum and obstructing the bile ducts, and also a mass in the mediastinum that could be causing the jugular venous distension. So I was really surprised when I didn't see a proper mass compressing all of these structures, but they were really causing, for example, the dilation of the gallbladder, and there was a very important pleural effusion. So I was really surprised by that. And just
So I guess the radiology we are working with, Maddie, is that there is image negative extrahepatic and intrahepatic biliary duct dilation without a clear cause of obstruction and a large left-sided pleural effusion. So what do you, I know that the path is probably sampling. I'm curious if you can make any progress on having a pretest probability of what that path might show.
I'm really not sure here. And I'm wondering if, so you're saying, so we saw a really distended gallbladder, but no obvious like stone or mass obstructing it. Is that right? It's just distended, but we don't know why. Yeah, I'm not really sure here. I think I'm concerned about malignancy. I think it seemed like a pretty large pleural effusion, so maybe I would go for sampling that first because it's the least invasive, but I'm actually really not sure here.
Yeah, I think the one thing that is easy to lose track of was what the neck mass represents. And I
Yeah.
don't think we got any radiographic correlate of what that means. I think that there's a whole range of possibilities here under the mass forming process, because in order to obstruct your biliary tree, there has to be a mass there. And that mass could be as benign as a stone, and that stone could cause so much backup of biliary pressure that you actually have biliary pleural effusions. So that stone could go all the way up and cause biliary. It could be as benign as she has a massive stone impacted in her distal common bile duct, and she has biliary pleural effusions. But that doesn't explain this thing.
Yeah.
So the question is, what does this represent? Is it true and unrelated? And I think if you ask yourself, what can cause image negative biliary compression and account for what this is, I worry that this represents a collection of lymph nodes. So I think that a rapidly progressive disease process characterized by a high LDH, a high uric acid, kidney dysfunction, possible lymphadenopathy, and sinister obstruction of the biliary tree would have me be most worried about a lymphoma. But this could be anything from a stone, and this is unexplained, to an infection that would definitely surprise me. But I'll pass the mic to you, Maddie, for any final thoughts you have, and then we'll learn from this incredible case that Gerardo had.
No, I think my only thoughts is this has just been kind of an incredible journey. And I think one thing for me, I've noticed just like looking back what I've done is I think there's just so much data. So I start like going through all the little data and then I'm like, wait, I got to back up. What is the larger picture here? So I think this is a good case to like try to practice that back and forth. And maybe something I kind of want to continue to work on is like trying to step back and like summarize the whole picture without kind of getting lost in the weeds. But this is really fascinating. I'm so curious what comes next. So Gerardo, please tell us.
Well, for this next and final aliquot, we have a biopsy. and the biopsies of the right parotid gland, and the pathologist reported a specimen from the right parotid shows tissues suggesting malignancy in myelin 5 system. The pathologist reported lymphoid population with presence of atypical giant cells. The pathologist suggested performing an immunohistochemistry study for CD20 and Ki-67.
So a lymphoma, it sounds like.
Yes.
Wow. And so did you, so is this, gosh, I have to remember, was this no Reed-Sternberg cells? Was this non-Hodgkin's lymphoma?
Yes, I've read everything that was put in the report because, well, something that I heard in the discussions because I followed the patient was that here in Peru, there isn't really many pathologists studying this type of diseases. So I think that because of that, because the oncologist said that, maybe that's why there wasn't like a thorough examination of the specimen. Yes, that is what I suppose would explain that there wasn't a report on the presence or not of these Reed-Sternberg cells.
Wow. Well, Gerardo, I just want to like really applaud you for presenting this in truly like a brilliant, expertly presented way. Like I'm really blown away. And this is a really challenging case with a lot of information. So like it makes it all the more challenging to kind of compile. So just really like round of applause for you. And yeah, I think reflecting on this case, I think really kind of the key, it's funny, it's like really at the second aliquot with the HPI, we were able to, Rabih got a sense that this was a systemic mass forming process, which is what this was, which is actually pretty fascinating how, you know, we did need to do this whole workup, but like you really could get a sense of that from the HPI. So just kind of showing how powerful the history is. And kind of to Rabih's point about in systemic mass forming processes, like the relative value of labs versus imaging. And I think, of course, the labs were kind of like consistent with what we were thinking about, but really there was more progress from the imaging and from ultimately kind of biopsying it. So yeah, really a lot to learn from this case. And Gerardo, thank you so much again for presenting it. Really well done. Rabih, I'm curious what
Thank you so much for your words.
Yeah.
You know, CP Solvers was founded in December of 2018. And, you know, I think it's very easy to imagine how hopefully it will continue to live on for decades after that. We're already 5 years in, and it's mind-blowing to me what you guys are doing. You know, Gerardo is shadowing and is able to somehow, in such a junior exposure to medicine, somehow put it together a narrative like this, where there's nobody who consumes medicine who's not going to be on the edge of their seats listening to a case like this. And you all know from being on VMR and putting cases together, you have to know a lot to know how to structure something, where to break it up. And the fact that we are running 10 minutes over without even realizing it is incredible. And I think, Maddie, you continue to humble me in how much you already know and how strong your appetite is for growth. And yeah, it really is. It's just mind-boggling to think that we're doing this all every single day, week in, week out. And it's palpable what Gerardo's growth potential is. And it's even made more real by seeing you actualize your potential in the last 2 years. Because I mean, think about it. Maddie presenting that case of cholangiopathy. I don't, how would you have been able to say and compare it to now? It really just, it's kind of terrifying. People talk about AI in medicine, and yes, that's very important. But I think you guys are growing way faster than any artificial intelligence that I can see. So that's just amazing. I don't have any bandwidth left for medical reflections, just a little bit overwhelmed by seeing you guys growing and flourishing. And of course, seeing him jump right in with 10 seconds of notice to scribe. And now, of course, last but not least, Francisco to guide us to the teaching point. So really, really amazing to be part of this work, y'all. It's a real treat. Thank you to everybody who's involved. All right, Francisco, take us home.
Oh my God, what a case, guys. Gerardo, congratulations. Great discussions also regarding the case. And I'm always amazed how we start in jaundice and we finish in lymphoma. I think that the cases at here at CP Solvers just start on one hand and they go around, and it's amazing. So we started with a 80-year-old female patient with jaundice and abdominal pain, and we started thinking about the differential diagnosis regarding jaundice, bearing in mind that she had scleral icterus, and we wonder all immediately that bilirubin is over 4 to 5. There are two ways, of course more, but the two main ways that we can think about jaundice is pre, intra, or post-hepatic. And we can also think and summarize this way of dividing into IM or hepatic. When we think about IM, it usually is associated with severe hemolysis, and we have cardiopulmonary signs like shortness of breath and chest pain. And then we have hepatic. We started thinking more about hepatic because this patient presented with abdominal pain. And it's really important to look for signs of liver failure. And we also considered that she maybe was a little bit confused. She had some neurological symptoms, and that really makes us suspicious of the inability of the liver to excrete toxins. And then, as always, it's in the simplicity that lies the answer. And Rabih told us this rule of thumb. And when we have a silent process, probably think that's extra hepatic. And when we have a lot of things more systemic, more complex, we need to wonder about if it's really hepatic. And as this case, when a lot of systems are affected, we start wondering about the systemic disease. And this systemic disease can be a mass-forming disease process or a radiographically negative one. And here we start to weigh the imaging versus the labs, and the imaging we would prioritize in a mass forming process, and we also, but they are both really, really important as the clinical history. So in regards to mass, we can have an extrahepatic that metastasizes to other parts, and we cannot forget that this patient had a neck mass, which was left us wondering if this was the case. And then we can also have a different mass that metastasizes to the liver. And we also have to think about hypercalcemia in acute constipation. We also need to exclude supplements and meds that could cause liver injury. And it's always important to acknowledge the negative parts of the history. And not only be biased towards the positive things. Then in regards to masses, we have infectious, malignancy, autoimmune, and in autoimmune, even though they are rare, we always have to think about IgG4 and histiocytosis. And one of the findings in this patient was that she had a JVP elevation that could be a sign of right ventricle dysfunction, and we started thinking about malignant pericarditis. But then on the imaging, this was not confirmed, and it left us wondering if it was the mass that was inducing this JVP elevation. It's always very useful to go back and forth in reasoning. It's normal, like Maddie did very well. And we must never forget to always join the clinical history, imaging, and labs. They all provide important clues. After the labs, we decided to take a CT scan and a biopsy. Left us with a final diagnosis, which was a lymphoma, which was inducing the compression of the intra and extrahepatic ducts, and we had a massive gallbladder also on CT. That was it.
How did that feel?
Good, good. Relieving the pressure.
Yeah, I
Just
know it's
saying.
nerve-wracking. I know the first time is nerve-wracking. You know what I think really stands out about your teaching points is how you managed to keep it so brief and focused in the face of an hour and 10 minutes of pearls. That shows that you were very selective in what you said, which is awesome. Really like that. All right, y'all. Thank you again. I hope to see some of you tomorrow for RLR on VMR.
Thank you so much.
Thank you.
Hi,
Bye.
everyone.
Thank you. Bye.